As long as I have these two hands and there are sick people to get well, I will use them. Hey guys, we're just going to start off. Actually, we're going to be talking about thoracic extension today, and actually Dr. Pascal will be, and also known as SwayBack posture, or just SwayBack. Before we get started, I just wanted to start off with just a really simple intro.
What's up, Warriors? Dr. Pascal here. I'm looking forward to seeing you guys soon on our webinars for 2021. The first topic that we're going to cover is what spine surgeons are now saying about restoring the cervical lordosis, right? There's a battle in our profession. Some chiropractors are saying that we shouldn't take x-rays and there's no value to doing corrective care. Well, it's a bunch of BS. We're going to look into what some of these orthopedic surgeons are doing and how they're even using CBP research to help guide them in restoring lordosis for patients when they do surgery, because they well know that when we put a curve back into the neck, patients simply do better with long-term outcomes. So we're going to be talking about that and how that validates our care as corrective chiropractors. We'll see you March 23rd.
That was awesome. I just love the passion. That was 3 years ago. It feels like just a moment ago, but that was 3 years ago, over 12 Warrior1Spine webinars ago. And I love the statement. What research is showing is you get a curve back, patients get better in the long term. It's as simple as that. I just wanted to take a moment here to again just thank Pascal for not only his commitment and his passion for Warrior1Spine, but also just in general, just his passion for being a principal chiropractor and staying true to the calling. And it just reminded me, I just wanted to go back a little bit and just share this is BJ's Palmer's parting words as printed in the glory going on. Today I have something more valuable than my own words to share. Here's a quote that is profound and has given many a chiropractor pause to think. These are BJ Palmer's parting words as printed in the glory of going on, 1961. Think about that, guys, like 63 years ago. A special quote from a man that was a visionary till the very end. So page 252, time always has and always will perpetuate those methods which better serve mankind. Chiropractic is no exception to that rule. Our illustrious father placed his chiropractic trust in our keeping to keep it pure and not sullied or defamed. We pass it on to you unstained to protect as he would also have you do. As he passed on, so will we. We admonish you to keep this principle and practice unadulterated and unmixed. Humanity needed then what he gave us. You need what we now give you. Out there in those great open spaces are multitudes seeking what you possess. Think about that, guys. There's multitudes seeking what you possess. And you got to really own that. The burdens are heavy, responsibilities are many, obligations are providential, but the satisfaction of traveling the populated highways and byways, relieving suffering, prolonging lives, adding millions of years to lives of millions of suffering people will bring forth satisfactions and glories which with greater blessings than you think. Time is of the essence. May God flow from above down his bounteous strengths, courages, and understandings to carry on. And may your innates receive and act on that free flow of wisdom from above down, inside out. For you have in your possession a sacred trust. Guard it well. And talk about the father of chiropractic he was talking about, Didi. And I love this just simple quote, is this, as long as I have these two hands and there are sick people to get well, I will use them. And if we can just embrace that, if you could just be all about people getting sick people well because you got two hands, just use them. If you could do that for a career, you're going to leave a very special legacy. And so why does Pascal do what he does? Why do we do what we do? What will the legacy be? Well, this is what we do, guys. This is why we do it. It's because of all the stories and how one story invites another story in. And the prior story is connected to a previous story. And you just become all about changing people's stories and getting sick people well. You'll have a fantastic an amazing legacy of a career. And this is a story that just started. I had the pleasure of meeting Jasmine. This is a story that actually started 2.5 weeks ago.
No ticks. No ticks, guys.
No ticks.
One adjustment. Jasmine has been diagnosed with very severe Tourette syndrome, and he's here now because somebody referred him in that saw Serena's story and heard about Serena's story. And you guys remember, you can go to the YouTube channel and see Serena's story. So Serena was 7 years old, diagnosed with Tourette's also, and I just saw her today. Actually, she's 24 years old, doesn't have Tourette's anymore, and that transformation took place, whatever, like 16 years ago. Desmond's gonna get his first adjustment. I just wanted to show you before he ever gets his first adjustment, so that you can actually see the transformation along the way. Sound good?
I'm ready.
You ready? Excellent. Breath in, all the way out. Good, excellent. Very good. You guys noticed that there was no ticks during that adjustment. Did you guys notice that? Did you notice that? Yeah, exactly. That's what I'm talking about. All the way out. Good, very good. Very good. And you notice no ticks during that adjustment. No ticks. No ticks, guys.
No ticks.
One adjustment.
No ticks. I like that.
You like that?
So he just started his 3rd week of care and he's doing amazing. Just every adjustment. He's actually come in a couple of times with like zero ticks. And he can't describe the feeling, but the way he describes it is that there's just peace. There's peace that's growing on the inside of me, which is pretty amazing statement. And, you know, one of the things I really want you guys to understand is that you guys are changing the world one spine at a time. And this is an amazing story that started 2.5 weeks ago, but some of you know this, but many of you don't. This story started a long time ago. This story actually started approximately, well, I would say about 22 years ago. And so what happened is, so Jasmine, a few weeks ago, Jasmine's aunt is Balwinder, and Balwinder came in and started talking and telling me about Jasmine and how Jasmine's had Tourette's, very severe Tourette's for I think about 15 years. He's 22 years old, same age as Rode. Rode just had a birthday yesterday. Actually, he's 22 now. He's the same age as Rode, and he's not going to school. He was going to school for architecture, and COVID for him was great because he was able to do all his schooling online, and he didn't have to go in person, because when he's anywhere in person, he just feels like he's a castaway, and he just feels like he's set apart in terms of a casting out of society, you know, a leper basically, and he just feels like people are just treat him differently. So since they're back in person, Jasmine stopped going to school. So so as he's explaining this during the initial exam, like mom's crying and he's tearing up, and I started doing the exam, and I got on C1, and it was just amazing. Like, it was completely shifted, and I just literally just shoved it the other way, and his tics stopped immediately. We have an intern that's with us for a few more weeks, and a chiropractic intern, and he's just like, he just floored, like he's just like floored, like, and I'm actually got my finger on C1, shoving it the other way, didn't adjust him, or maybe I am, whatever, but I have it over there and no ticks, and I'm going to mom and said, "You see, mom, no ticks," and like she is just blown away. So it's the first time in that moment that she saw her son without ticks. So the mom is Balwinder's sister. So Balwinder actually came in a couple of weeks ago, or I guess about 5 weeks ago, and says, I got my nephew, and do you think you can help his Tourette's? And I said, well, actually, let's get him checked. There's a strong possibility. It depends if it's coming from spine issues or nerve system issues. And obviously I know it's coming from nerve system issues. And she said, well, I want to come in because I actually heard about Serena's story. And I saw Serena's story, so I thought maybe you could help Jasmine. So that's how actually Jasmine came in, is because Balwinder actually saw Serena's story. But Balwinder's story in the clinic, she's been a patient about 15 years. It goes further than that. So how Balwinder actually came to the clinic is through her Balwinder's daughter. And Balwinder's daughter came in. She was a university student. And then, she came in. Balwinder sat through the report. Right after the report, it wasn't about her story anymore. She started care, but she says, I want to get my son checked. So Baldwinder's son comes in the next week, and Baldwinder's son, why she want to get him checked is because he's had chronic migraines like forever, and really, really severe, to the point where he's in his early 20s, dropped out of Carleton University. The reason why he dropped out of Carleton University because he can't sit through like a class, let alone a full day. So he's actually put his university schooling on hold because of the migraines. And so he comes in, we do the report, and we start adjusting, and we saw change immediately. And his migraines started to dissipate, and he started feeling better. And that was the first week. The second week, he's getting better and better. And then the weekend hit, and I saw him on the Thursday, and then the weekend hit, and I guess he had this massive, massive migraine that started. So they went to Emerge like they'd done before. But in Emerge, they wanted to start using a new drug. So they gave him a new drug, and he actually died on that Saturday in Emerge. And so Baldwinner comes in on Monday, and I'm going, hey, Baldwinner, where's your son? Where's your son? And she basically said, well, he passed away on Saturday. And I'm just going, so it's one of those stories that, I don't take this for granted. It's life and death to me. This story just kind of woke me up again to a deeper level of depth. It's life and death. Baldwinner's son passed away. She continues under care. A few weeks later, she comes in, and I'm not making this up because I can't make this stuff up. She comes in, and in her religious beliefs and her spiritual beliefs, she believes in reincarnation. So she came in with the request, and this is what she says to me. She goes, listen, I want to actually reincarnate my son, so I want you to start adjusting. Give me the same adjustment that you were actually giving my son, because I want to get pregnant again. Now, Baldwinner at this point is in their, I don't know, mid 40s. And she wants to get pregnant, and I'm going that doesn't even line up with my spiritual beliefs, let alone my, my chiropractic beliefs. This is same adjustment as son. That's you put that into the road sheet. But I just go I respected her request, so I started adjusting her, and sure enough, 12 weeks later, she comes in and she's pregnant, and not only just pregnant, she's pregnant with twins. Now, that's a whole other story I'm not going to get into, but it's the truth. So, yeah, so she actually delivered two sons. She had two sons. And so that's another side of the story I won't get into. But let's talk about Serena's story. So how Serena came into the clinic is because Irene. So Irene is her mother, and you can actually see Irene here on this picture. And Irene, you guys met Serena and Irene if you guys were at Tremblant about 20 years ago, because this is her standing up and just sharing her story. So the way Irene came into the clinic is because her friend Pam. So her friend Pam was a patient of mine, and she's a massage therapist, and she's Irene's friend. So Pam one day comes in and says, hey, do you think you can help Tourette syndrome? And I simply said, yes, it's a nerve system disorder. It all depends on if the problem is coming from the spine or spinal cord. I might be able to help. Let's get Serena checked. Now, why Pam actually thought about maybe the fact that we might be able to help Serena is because Pam met Gloria, and Gloria has a daughter whose name is Ashley. And Ashley's story is so Ashley actually started care with me when she was in her kind of preteens, or maybe 11, 12, 13 years old. And her story goes where she was actually bilingual at the age of 2. She could speak. She was very, very smart, and just kind of normal kid, right? Actually, probably pretty gifted if she knew two languages at the age of 2, 3 years old. Anyways, her story goes at the age of 2, she stopped talking. She stopped walking. She could stand still, but she couldn't walk. She couldn't get up off the floor by herself. She couldn't do stairs. And so Gloria came to the report, and then they started care. Ashley started walking, started going up stairs, started actually, standing up. So one time Pam was getting adjusted, and then she saw Ashley walk. So Ashley wasn't walking. Then she saw Ashley walking up the stairs to get adjusted in my little adjustment area. And then that's when Pam actually asked me whether she thought I could help Serena because she saw the transformation with Ashley. Now, with Gloria and Ashley's story, there's a side story here. This is also Donna, who's had been a patient for a long, long time. Donna also saw Ashley, well, heard about Ashley's story, but saw Ashley's progress, talked to Gloria. Donna one day asked me, hey, do you think you can help Jody? My friend's daughter just is a really, really good soccer player. She just got involved. She just got in a very serious car accident. She's paralyzed from the neck down. Do you think you can help her? So then Jody comes in, and well, this is part of Jody's story.
So when Jody says, doctor, do you think you can help me walk? I want to walk. Come on up, Jode. Let's go. They've been waiting for you. Do you want her to walk, or do you want her? So you want to stand for them, Jode? We got her curve back, but she was still really flexed this way. She just showed me yesterday. Want to see something cool? This is brand new, okay? In bed, they wanted to put her in a nursing home. I got that brace. I got all the little braces along the way, and right now she's got no brace. Thanks a lot, guys. God bless you.
So in that video, you could actually see the blonde is Donna, the patient that referred her mom in with Jody. And so and I could go down another downline of stories from this story, but we're going to come back to Gloria and Ashley's story. And how did Gloria and Ashley's story begin? Is because of Brad's story. So Brad is Ashley's brother, Gloria's son. So Brad comes in, and we have our texier go over the findings and stuff. Brad comes in because at that point, in the late 90s, I was actually the chiropractor I was a team doctor for Carleton University Ravens hockey team. And Brad comes in with a sore shoulder. So that's the history. So I'm going in, it's like, so, my tech says he dislocated his shoulder last night, and it's really, really sore, and he popped it back in. And I'm, in my mind going like, obviously it's really, really sore. He just dislocated it yesterday. So I'm going in and I have a choice, right? What am I going to do? So I go in and I just stick to what I do. I stick to what you guys do. I stick to the principle. I stick to, let's check your spine. Why? Because that's what we do. And once we check the spine, we find subluxation. And what we do next is we take x-ray. Why? Because that's what we do for diagnosis and prognosis, and to know exactly what to adjust, when to adjust it, and how to adjust it. And so he came to the report. Now, all of a sudden, the report didn't be like, he sat through the report. Brad's story wasn't about Brad anymore. He says, these stories are so amazing. Do you think you can actually help Ashley, my sister, because this is her story? And so, guys, all your stories are connected, and you guys could do this in your practice. You guys have uplines and downlines, and you guys got downlines being created right now. So continue to share those stories, continue to multiply those stories, because the stories within chiropractic has always been the most important thing in chiropractic. And you know what? For all of us on this line, what should be our primary driving force other is that God's giving us a calling. And he's giving us a calling, and he's giving us two hands, and there are a lot of sick people out there. And just continue to use them to help them get better. And it's as simple as that. Pascal?
Thank you, gentlemen. Thank you for having me on again. I'm excited to be here today and talk to you guys about, I think, a topic that everybody would know, more commonly as SwayBack posture. And you hear people coming into your offices, you probably hear, someone say, oh, I think I have SwayBack posture. You might see it on the internet. And so the funny thing is SwayBack posture ties in very beautifully to thoracic extension. To me, they are identical. Thoracic extension would be more of the CBP protocol, the scientific approach, or what we would call this, spinal problem. SwayBack is the layman terms, right? And I just put these two and two together because I actually Googled SwayBack posture, and the definition that it brought me to truly sort of defined or elaborated thoracic extension. Okay. So can everybody see my screen? You just give me a thumbs up if you can. Awesome. Thank you, guys. Thank you. Let's go here. All right. So I went on to our good old friend Google, and I Googled SwayBack posture, right? And so it brought up this picture, and I cut off all the other common postural problems, but the one on the very left is SwayBack posture, right? And so this gentleman doesn't actually have SwayBack posture. He's trying to demonstrate what a SwayBack posture would look like. Now, he doesn't get most of it right, but he gets the thoracic extension piece perfectly, being his shoulders, right? Let's picture that as T1, are sitting posterior to where his T12 would be in lateral profile, okay? But here's the cool part. So when I looked up the definition of what I had for SwayBack posture, it said, SwayBack posture is a particular type of poor posture that often leads to spinal pain. Obviously, we know that. People who exhibit SwayBack posture have exaggerated curves in their lumbar spine, right? So increased lumbar lordosis. They have forward tilting hips, aka increased sacral base angle, and the appearance of leaning back when standing. And I put in parentheses here, T1 posterior to T12 on X-ray, okay? What this young man did not get right, though, is that when they have this posture, their head has to push further forward, because right now, right, let's just say this guy still has a good neck curve. Where is he looking? He's walking around looking to the sky. So the last piece that they don't include in their definition is that it comes with forward head posture and most of the time a cervical kyphosis, which we're going to call cervical flexion, right? We're going to use the actual mechanical terminology of how this all fits in. So here's an x-ray of someone that was actually put up by another doctor on the Spinal Health Distributors Facebook page, where we put up x-rays and we sort of help each other out. We put up an x-ray and someone might say, hey, have you guys seen a posture like this before? What do I do for a spine like this? And so when that doctor put up this spine on the Spinal Health Distributors Facebook page, I thought, perfect. Here's a great topic to help other chiropractors try to understand what's going on here. And this is a textbook thoracic extension case. So we see T1 behind T12, right? We're going to see that this person has an increased lumbar lordosis. They've got a forward tilting pelvis or increased sacral base angle. And what do you notice about their neck? Cervical kyphosis, aka that's also, we call it flexion, and their head goes forward, right? So here are like the three main bullet points that you want to look for in anybody that would have that thoracic extension posture. So if you're not taking lateral thoracic films, I've hit on this so many times, I can't tell you enough how important it is to analyze the entire spine from the side and from the front. It is crucial, right? Because if you don't understand what's happening below, you are going to lack in your ability to get great correction. So number one thing is we look at T1 posterior to T12 on your lateral thoracic film. Then you're going to look down to the lumbar spine, and you're often going to see what's called pelvic flexion, aka increased sacral base angle. So the pelvis ends up tilting forward, right? It tilts too much. And so what that means is, let's try and hallucinate this if I can. So imagine right here, okay? The hip joints, which you can't see here, are the axis of rotation. So my x-axis, it would be like a dowel, right? The dowel runs through the pelvis. So we're kind of looking, if you see my red dot there, my red dot is us looking at that dowel. While the pelvis rotates down and forward on that dowel. Rotation in that direction is called flexion. Rotation in the opposite direction is called extension. So the ribs, the thoracic spine rotates, whoops, trying to do this with my mouse, it's not easy. The ribs or the thoracic spine rotate backwards in extension. The pelvis compensates and rotates forward in flexion. Your brain is really smart and it wants to counterbalance. So you have flexion in the pelvis, you get extension in the thoracic spine. So guess what that leaves you for the cervical spine? Flexion. So you get flexion, extension, flexion. Okay. What is really important to note here, okay, I put it on my bullet point number 2. It's not just increased lordosis of the lumbar spine. It's not just increased sacral base angle. It is beyond that person's normal anatomy, okay? Ed alluded to this earlier. You know, we've done multiple Warrior webinars now. So I'm using concepts that we've hit in the past. And so some of these things you might go and like, what is he talking about, Doc? And if some of those concepts, like things like pelvic anatomy, or pelvic incidence angle, if we don't know what that means, you can always go back, go to previous Warrior webinars. That information is there. But the pelvic incidence angle is what's normal for any given patient's pelvis. So some patients have very deep or increased pelvic incidence angles. They're going to naturally have higher lordosis. They're naturally going to have a sacral base angle that is increased. So I am not talking about those patients. I'm talking about patients where, you know, the anatomy is normal, right? And they are increased in their lordosis and their sacral base angle beyond their anatomy. And I'll show you an exact example of that here in a couple of slides, okay? To me, this is a classic sign of a weak core and tight hips. We see it all the time. I think it's becoming more and more common, obviously, as the younger generations come up and they spend more time sitting, more time on digital devices. We're seeing far more youngsters who cannot properly engage their core. And this is a classic example when you see this type of thoracic extension posture, okay? So we talked about all those bullet points. So 1, 2, and 3, that's what you're looking for. T1, posterior to T12 on x-ray, increased lordosis, increased sacral base angle, and generally you're going to have forward head posture, most of the time also with flexion, which you can also think about as a cervical kyphosis. That is what flexion means, okay? It is not posterior translation. I am just putting this to be very clear. I'm also going to show you a slide where one person is shifted backwards. They're posteriorly translated versus the other posture that has thoracic extension. They are two very, very, very distinct postural issues, okay? And their home rehab is very different from posterior translation to thoracic extension, okay? So let's go through these one at a time. And by the way, for anybody who's not using a software to measure x-rays, I believe this software is called SurgiMap, and I think it's free online. You download the software onto your computer. So if you're taking digital films, like this is not a full spine x-ray. This is a stitched x-ray, cervical, thoracic, lateral, and then the software simply stitches all 3 films together to give you this lateral picture of what the patient looks like. So these softwares are relatively cheap and available to most people, right? I use the Posture software, which I absolutely love, because for a spine geek like myself, it spits out all of the data that I could possibly want to know, right? And so here is an x-ray of a young lady. I'm going to show you all of her x-rays, and I'm going to tie it in at the very end. So every one of the x-rays I show you from now on to the next 4 slides is all the same young lady with a thoracic extension posture, okay? So I look at my T1. It is clearly posterior to T12. What do I mean by that? If I drop a line, a vertical line, sorry, I'm trying to draw that straight with my mouse. Let's say I drew that vertical line down. Hopefully everybody can hallucinate with me that that was a straight line. If you get it though, you'll look at that plumb line down from T1. Everybody can appreciate it is posterior to T12. The software here, Posture measures it for me. It's 41 mils. So she has 4 centimeters of shift from her T1 to her T12. That is a substantial shift in a very small section of your spine, okay? And then we look here. This is important too, because an x-ray I'm going to show you later on, it says the thoracic spine measures 50 degrees, but her kyphosis is measuring 42.3. Normal is 44, so she's bang on to about normal. Oftentimes with thoracic extension, you're not going to get a ton of hyperkyphosis. Obviously, if someone was extended way further back, like if they're kind of coming way out here, there has to be some level of kyphosis to compensate as the head comes forward. So you will see some increase in kyphosis in very bad cases, but I'm going to say most of the time you're going to see little, if not the normal kyphosis, to maybe mildly increased thoracic kyphosis. Okay, that's important because that's how we also identify or separate it from that posterior translation posture. Okay, so T1 sits posterior to T12 on the lateral x-ray, and most of the time, a fairly normal kyphosis. So you see that, you look below, okay? Pelvic flexion, we talked about this, right? If you look at her femur heads here, that's my axis of rotation, right? Her sacral base angle and her lumbar lordosis are increased beyond her anatomy. Okay, very quickly, I'm going to just refresh people what I mean by beyond anatomy. Okay, there's a full Warrior webinar on the lumbar lordosis and measuring this. So you put a line across the sacral base. I find that midpoint, you're going to put what's called a 90-degree line, right? So that's 90-degree angle from the midpoint of my sacral base. You find the femur heads, and you're joining the femur heads to that point. Okay, so where the 90 meets the sacral base. That angle is called your pelvic incidence angle. It determines how much tilt is normal in any given pelvis. Okay, based on that, we have a formula that is used to measure what normal is for a patient. That formula is in one of those previous Warrior webinars. Okay, the average in the population is 56. Okay, so this patient is measuring 49. And the cool thing with the Posture software, if you're not using it, I love this software. I don't have to do any of these measurements. I just put the dots on and it predicts it right here. It predicted 36 degrees for this female, 36 degrees. So she should have a 36-degree lumbar curve and a 36-degree sacral base angle. So ARA stands for the lumbar curve. Sacral base stands for, SB stands for sacral base. So we have her pelvic incidence. We measure it. It gives us a value, and it says, hey, patient, you should have 36 degrees of both lumbar curve and sacral base. Well, the measurements here show me that she has 43 degrees of curve, and she has 45 degrees of sacral base angle. So those are both increased beyond her anatomy. So she has too much curve in her low back and too much tilt in her pelvis, okay? Then we come up to the neck. So again, this is her thoracic spine. This is her lumbar spine. This is her cervical spine. Okay, so we're going to see typically forward head posture. I think everybody can see that, right? T2 is anterior to my, T2. C2 is anterior to my C7, and it's being measured at 34 millimeters, so it's pretty substantial. And it's not only forward head posture with loss of curve. If we look here, she's 6 degrees what? Not lordotic, she is 6 degrees hyphotic, aka flexion, right? The spine is starting to, if this is a dowel or the x-axis, the spine is starting to rotate forward around that axis. So you will see that classically in almost every single thoracic extension posture, okay? Now, on one of my earlier slides, I told you this is not posterior translation. So my slide here is clearly depicting the difference between these two postural problems, okay? This is a thoracic extension posture. This is a posterior translation, which typically leads to hyperkyphosis. Okay? So what do we see in the extension posture? We talked about it, the increased low back curve, right? And the increased sacral base angle, right? We said 45 or 43 degrees of curve, 45 degrees of sacral base angle. T1 is sitting behind T12 on our lateral film, and we have loss of curve with cervical flexion. We come over to the posterior translation posture, and this is very different, okay? Translation means that T12 is sitting behind S1. So if everybody looks here, my T12 is sitting way behind my S1. In my thoracic extension posture, it might be a few millimeters behind. Like the software is measuring it here at 4 millimeters. 4 millimeters is virtually negligible. This is not a translation posture. T12, if I draw my line straight down, best I can, it is lining up. The posterior inferior aspect of T12 lines up almost perfectly with my S1. Okay, so there is virtually no translation in this posture. This one, tons of translation. When you have that kind of translation, usually you're going to see the opposite. So not an increase in lumbar curve, you're going to see a decrease in lumbar curve and usually a decrease in sacral base angle. So what do you see here? 21 degrees. Normal is 40. So 21 means it's decreased. For lumbar curve, let's go up here. Lumbar curve is 28 degrees. Normal is 40. So it's decreased. So it's the opposite of this thoracic extension posture. Okay. So you have translation backwards. Generally, you'll have a decreased lumbar curve, a decreased sacral base angle, because of which, too, because T12 is so far backwards, now you need that kyphosis to compensate. So you're going to have an increase in thoracic kyphosis. When you have an increase in thoracic kyphosis, usually you're not going to have a cervical kyphosis, right? The spine kind of goes in opposite patterns. So with that kyphosis in the thoracic spine, look at this neck curve up here. You actually got a decent lordosis low down, right? Those two necks are extremely different. This neck versus this neck are two completely different necks. So they don't have the same protocols, right? You don't adjust them the same, you don't send them home with the same exercises, and so on and so forth. So this person, we've gone through this before, they would need something to drive the whole posture forward. They're going to do Titanic exercises. Do they need extra core to stabilize? Of course. But they're going to lay on that big posture regainer to flatten the thoracic spine, drive the posture forward, bring the head back. This person has a different set of home protocols that we're going to go through here. Okay? So how do we correct thoracic extension? Well, I'm sure most of you know by now, this is what we're going to do right here. Exercise, adjustments, and traction, right? The E protocol, the CBP protocol, the CLEAR protocol, right? These are all the protocols from those doctors who really got into the nitty-gritty science, the how to fix the spine. It's always exercise, adjustments, and traction, right? This is what we do. All right, I'm going to show you guys some videos of the exercises that we're going to do for this patient. So number one, they lack cervical curve. So we're going to do what? Prolordotic neck exercise video. And by the way, this is my YouTube channel. I always refer to it on my last slide. I say, go to my YouTube channel, check out these videos, right? They were done for a reason. So if you've never seen this video, this is the prolordotic neck exercise, okay? So you're going to first see, I don't know if she's going to go right into the bad rep. There's something I want you guys to be very careful for with patients with thoracic extension. I think this is the one who's going to do the bad rep. Yeah, this is the bad rep. Okay, I see this in my clinic 24/7. I warn all my patients of this. People want to get their head back. They're keeners, right? So they want to bring their head back. So what do? They do thoracic extension. If you're looking at Dan here, you can see his shoulders are clearly sitting behind his T12, right? So if someone already has a thoracic extension posture, you have to be on top of them to make sure that when they do their neck exercise, their prolordotic, they are not extending through the thoracic spine. Crucial. If you have to, stand them against the wall, put a yoga block behind their shoulders so they can't lean back, and then let them do the prolordotic against the wall, okay? So that's a bad repetition. The good repetition, which you'll do in a second, so, we're trying to exaggerate that thoracic extension. I see this all the time. And when patients have thoracic extension, I mentioned that they have a weak core. It's just natural for them to lean back. They don't have the ability to want to stabilize through that midline. Okay, so how do we have them stabilize through the midline? We usually tell them to engage the abs. Tell them to make your tummy hard before you lean back. So the head should come back, boom. Shoulders don't move, core is engaged. Now you're getting neck curve without having any thoracic extension. Okay, so the prolordotic neck exercise. So if you've never seen that video on my site, check it out. I have never done a McGill curl up video, but I probably should because I talk about this exercise so much. This is one of my favorite exercises for core stability, period, but it is my go-to exercise for everybody with thoracic extension. It's like this exercise was made to correct thoracic extension, okay? Patients laying on the ground, they put their hands behind their low back. The reason that we're putting the hands behind the low back is because we want them to feel that lumbar pressure engage down. You want them to actually feel that lumbar flattening. Those who have thoracic extension, they have that deeper lordosis. There's a nice big gap there. They put their hand back there and they can feel that hollow. When you have them, then, in some ones they're going to show you, they're going to tell you to put the leg down. You can put the leg down, boom. Well, what did he just do? Okay, I'm going to back it up a second because that was perfect. You're going to notice as soon as this gentleman comes up, you're going to notice his lumbar spine flatten. I tell my patients, suck your belly button down to your spine, put pressure down onto your hands, try and flatten this. You're going to see his lumbar curve flatten. You're actually going to see some pelvic tilt decrease as well. So he's going to decrease the sacral base angle. Then he's going to bring his shoulders, aka T1, he's going to lift the shoulders. He's not lifting T12, he just lifts the shoulders. So he's creating thoracic flexion, right? So here it is. Boom, watch his core engage. You're going to see the lumbar spine flatten, okay? If we were to x-ray this patient in this position, they would have a decreased lumbar curve, decreased sacral base angle, and clearly thoracic flexion. It is the perfect exercise for patients that have this, okay? So if we're not addressing the thoracic extension, if you're not addressing the core, you're going to lack results in correcting that curve, right? If you think back to that young lady, you know, who's extended backwards, or that gentleman I showed you on that very first picture slide, you know, he's still looking to the ceiling. You think about trying to put a curve into the neck, and to put the curve into the neck, yes, you do need to get a cervical dental roll under there. But if you're putting a cervical dental roll under them, but you're not doing anything to strengthen the core and posture, if they stay extended, the spine will never be able to manage to keep a curve in position. Because the curve, if you guys can see my icon where I'm talking, the curve makes you look up naturally, right? So if someone is extended, you know, they're not going to walk around looking at the ceiling, right? And so naturally, they're always going to compensate by keeping their head down and in flexion. So we need all three. You need the prolordotic neck exercise, right, to strengthen the neck musculature. You need the McGill curl up to strengthen the core and stabilize the low back. And then we need the cervical dental roll to rehabilitate the ligaments and hold that curve in position. Here's a really important point, though. With thoracic extension postures, generally speaking, you see this more on younger, flexible patients. Because they're younger, they're more flexible. And because T1 is behind T12, I usually use a large cervical dental roll on them. So let's say it's, you know, if we remember our measurements, and by the way, same thing, this video on my YouTube channel, the how-to in terms of using the cervical dental roll, okay? So we need this prolordotic neck exercise. We talked about that. We need, awesome, McGill curl up. We need the cervical dental roll. I was just talking about the sizing. Right? Usually we say the large is for taller adults, but if you look at the sizing, it usually says 5'9" or above. But here's the more important factor, more flexible adults. Thoracic extension is usually a young, flexible patient, right? They've got that weaker core, they're leaning way backwards. I'm almost always using a large cervical dental roll, even if they're 5'4". You know, they're small in terms of an adult size. They still need a larger dental roll to drive T1 anterior and put that curve back in the neck, okay? So with those thoracic extension postures, don't be shy to use the large cervical dental roll, okay? So hopefully that puts it all together for you guys. Some simple things to look for, 3 very basic rehab protocols to use in that posture. As always, as a thank you for supporting dental roll products and helping to move research forward by buying dental roll products, you have a coupon code here that you can use, WQ324. It's good until August 6th off of anything, obviously, at the dental roll store. In Canada, that is. And then my contact information, plenty docs are sending me cases all the time asking me, you know, what should I do here? What should I do there? Not a problem. Send me an email and I'll respond back when I get a chance. And then lastly, there's the link to obviously my YouTube page, which we were just on with some of those videos. Thank you. And I will see you again one more time, I guess sometime in fall. I don't know.